All right, thank you so much for that introduction. I am sorry that my camera isn't working, but we got to see myself and Bill there for a moment. I am going to talk to you today about the CAREN, and I often describe it as a bridge from the clinic to the real world. And today we'll also be talking about the CAREN as a bridge connecting research and the clinic. The picture on the right is from Quincy, Illinois, where my grandmother passed, but she lived into her 102nd year, so we just had her celebration of life. The other picture is Bill and I collaborating. Well, I mean, we're standing next to each other, but I guarantee you we're collaborating while a student is on the CAREN with a patient. A little bit about us. My doctorate is in physical therapy. I primarily treat patients in the clinic. I incorporate the CAREN into treatment for most of them. I say I'm an accidental researcher because of the way my clinic work raised questions and drove me to find answers. Bill also does train people how to run the CAREN occasionally, but mainly he runs our CAREN full time. I am happy to say that he likes research, but he's often pulled into it by his partnering clinicians, and I am guilty as charged. And he has his own brilliant questions that also sparks research. Speaking of brilliant questions, just like Eric said, please put any of your questions or comments in the chat, and we'll get to them as we can, because the end is my favorite part, and that is questions. All right, this is our story of how we use the CAREN. The objective of this talk is to help you understand how the CAREN is transforming patient outcomes by merging clinical practice with innovative research. I'd like you to understand CAREN's dual role, both pre-built and custom applications. You're going to see cases where this adaptive technology enables real-time adjustments for personalized therapy. Hopefully, you'll recognize how clinical work can drive research questions and vice versa. This truly is evidence-based practice. You're going to see those adaptations with different populations of patients and those translational insights. Hopefully, we can explore collaborative opportunities between clinicians and researchers, and the greater public to advance rehabilitation science. I know I have lofty goals for this talk, but that is the objective. All right, CAREN as a bridge. We're going to talk, well, clinically, it's no surprise to any of us. We break down components of task-specific training in a safe environment. That's what the clinic is. It's a very controlled space. However, we don't allow for some of that complexity of life. We use the CAREN as a bridge from the clinic to real world and to research. What? How do you do that? I'm so glad you asked, because now comes the part of the speech where we have audience participation. So you all registered for this. I will call on one of you randomly. No, I'm just kidding. That's awful. All right, so research looks at specific patient populations, right? They look at outcome measures. And hopefully the results of that research becomes part of clinical knowledge base and treatment protocols. That's why we do this. The CAREN allows us real-time data collection. We can treat patients and answer research questions at the same time. We can treat patients while publishing papers. Now, I could talk all day. I really like what I do, and I really love using the CAREN, but I like pictures and videos way more than people talking at me. So here are some examples you're going to see today, as well as a little bit of our research. All right, first case. When he had a gunshot wound to his brain, he was 22. He wanted to walk again. Now, they came to me because of the CAREN. He had had a lot of different therapies over the years, and he was having a hard time looking up during gait and balance. Traditional physical therapy was doing well, but because of his decreased sensation and weakness on his right side, we really needed to add a little bit more. So in comes the CAREN. We use so many applications, but we're going to highlight some of the pre-built and custom apps. I put a little bit on there for those that use the CAREN so that you would know which applications we're going to look at today. But for those of you that don't have a CAREN, we can just talk about what we're seeing. Now, our dual impact. You will see clinically improved gait and balance. as well as increased engagement of the patient. Because honestly, it's just fun to gamify, right? Gamifying treatment makes it so much better. Research. All right, data and publications are forthcoming. We just need time to write. I don't know how you PhDs do it, but we will get a little bit more out there. Now, takeaway, evidence-based practice and collaboration makes us better clinicians, better researchers, as well as improving patient outcomes, which is honestly why we do all this. Okay, videos are next, because even I am done just talky. It's time to see the evidence. The proof is in the pudding, as they say, although I don't know why we're mixing our results with food, but here is our first video section. I'm gonna orient you a little bit. Each of these 4 panels, the lateral view is above, it is synced up to the posterior view underneath. At the bottom, you can see the progression over time, which is about a year. For this application, he has to look up in order to interact with the screen. We have that dual task with gait, motor planning, using one upper extremity in order to swat at it, which means he only has one upper extremity for support. If this was a different talk, I would ask my students what they're seeing, how he's behaving, what their cues would be. But for you, look at what you see with his gait, his trunk stability, his upper extremity use, especially when he's focused on that task or turning his head from the beginning to the end. We have a lot of information that we're getting from this, but the patient is also getting a lot of information and progressing over time, which is what we want. Time to stability is perturbations for those of you that don't have CARENs. And these perturbations are so important because in the clinic, we give those extra external cues. So we're either pulling or pushing the patient, or something underneath them clicks or gives them some idea about what we're doing before we actually do it. For this application, the CAREN also gives us the time. It's calculated for how long it takes for them to regain their balance. Now, for the patient view of this, I want you to notice at the beginning that there's bilateral upper extremity support. Then we go into right upper extremity support. Now, remember, the right side is the weak side. Now we go over the next panel, number 3. We have the left upper extremity support. By the 4th one, we have hovering bilateral upper extremity. So he's ready, but he's not using it. And finally, by the end, we have no upper extremity support. Microbes. Now, you have a whole lot more to look at with this. But again, from the beginning on the left to the end on the right, over time, the top and bottom are synced. Microbes is far more stimulating. It includes different tasks in the same application. It has optic flow, so that stuff moving past you when you go further into the body in this part. We have increased cognitive load with interacting with the screen, so he has to have his head up, as well as gait adaptability and variability. We have motor planning activities. He has to step over something while walking. We have different activities that require him to move and interact with the environment differently than we ever could do in the clinic, but is more realistic in real life. Again, we have the same progression over the year. You can see many things, including gait quality, what's going on with that right leg. If you look at the lateral view at the top, you can see how gait speed has also increased. Now, this video is a little longer, so I encourage you, if you're having thoughts or questions, go ahead and write them down. As I said, this application has different sections. So when he stops, he's doing something different, moving through. And I like to say it's the human body. But of course, if we have somebody in veterinary medicine, we can always say it's a dog or a cat. All right, so now we have gait feedback. This is the human body model. Flexion and extension of the knee is on the graph, as well as a real-time model of how his leg is moving, and specifically that right leg, which is why we have him turned so that he can see that right knee extension. So this is looking at that representation. He's looking at himself on the screen. He's doing this so he does not have to look down. That is his actual movements on the screen. We're also showing him the graph. So we can see what his knee is doing, right? He can't feel it. So having it on that graph, he can see what his right and left are doing and how the right is different. That right leg has that decreased knee flexion with that swing phase, that hyperextension with initial contact and stance phase. This was incredibly useful to his understanding, his motor planning, and his gait recovery. My CAREN users, you know this marker set. You know how much data we have obtained from this over time. So if you look laterally, those top panels, you can see how it's changed. And again, you can see that gait speed has also increased. Gait Analysis is a custom application that we made. It shows a visual representation on the screen of just his feet, that real-time feedback of only the shoes. I've showed you before how much information was on the screen for the human body model. Now we're decreasing that visual noise. He's keeping his head up. He's focusing on step length and step width and seeing where his foot goes because he can't feel it. But we're able to do that while he's looking up the whole time. And again, you can see that change over the year. Locate Fixate is another custom application that we built. And by we, I mean Bill, but I'm totally going to take credit for his creations because they're fantastic. With Locate Fixate, what he's doing is he's tracking an object while standing or walking. We started out with that plain background, which you can see from that posterior view on the bottom panels. And then we went to an intersection at our campus. You'll notice that that right upper extremity support is there for the first two panels, then the last two left upper extremity support. The third and fifth panels are walking. And you already saw how difficult it was for him that first time, which is the third panel, of him walking and doing something else at the same time. That dual task was very difficult and something that we were able to obtain and work on while he was on the CAREN in a very safe environment. You saw the safety protocols kick in so that he could regain his balance. All right, this isn't the CAREN, you say. Yes, surprise, it's the Andago. It's also made by Hakoma, which is under the DIH umbrella. If you're not familiar with it, I'll just let you know, it's a body weight supported overground walking system. This allows us to have that walking away from the virtual reality and into actual reality, or we just call it reality, to work more on that gait and balance activities in a safe environment without the walker. And you saw those differences between him walking slow with his head up and then fast, he had to look down. All right, so this case, you saw adaptive technology for real-time adjustments. We were able to change it for him. Multisensory feedback that enhanced motor learning. We got him looking up. We got him paying attention to that right leg with gains in his increased weight bearing, but also his improved knee control for gait and balance. All right, let's move on to the next because I just love talking about what we're doing. Case number 2. We have a 32-year-old female with encephalitis. Now, for the sake of time, I'll just show the custom applications we made, we being Bill. We made it for her, okay? So we have the dual impact and the takeaway statements are the same. So believe it or not, I want us all to work together. All right, so this is that same application, that custom application that we made for the patient to be able to see her feet so that she doesn't have to look down. She knows where they are. I did not get her on the CAREN right away because of other issues, but you can see the differences in her gait in just over a few months. I didn't see her for nearly as long as I did that first case I showed you, which is why you only have a couple to compare. Notice her gait, speed, and pattern, her arm swing. She even looks over at me in the last panel when she's walking and doesn't lose her balance. This is why we made this one. Now, this application is made for her, since one of our primary goals was to return to horseback riding. We have nothing that moves like this in the clinic. We use the CAREN as a bridge to work on those components that she needed to return to horseback riding. We changed it over time so that it was more accurate in her seat or her stance. We also got straps for stirrups. We got a strap for reins for her to hold on to. So you can see that in that final panel. So she's sitting more accurately. This is one of the many areas we could have used collaboration. See if anybody else was developing anything for horse riders, anything on the CAREN that moved like this, or if you had any other patients that you were working with as well. Fun fact, did you know there's not a lot of research out there about riders of horses? I know, I could talk more about that, but we can move on to the next section. We learned so much about the gait of horses during this process, including canter, trot, walk, etc. We changed the programming over time based on the feedback of the patient and her husband. She and her husband ride horses. They know how they move. And you can see in the bottom panel, I'll try to get us all to trot here. So you can see how the CAREN is moving from the first panel to the last panel and how much more complicated, I would say accurate, those movements are at the end. There's not a lot of research on riders, as I said, but this could be a way for us to collaborate on the treatment of our patients, or even perform research studies on riders in a safe and controlled manner without all that messy horse personalities. For collaboration, we need to talk. Researchers need subjects. Clinicians need resources. Universities and hospitals have equipment, but we need normative data sets. We have the same goal or the same end, data collection and clinical application. Case study 3, our final one. I have a 76-year-old female, and for those that speak French, I won't even try to pronounce it. I will just say MdDS. She was dizzy. She was dizzy for a long time. And like a lot of patients or subjects with dizziness, with visual stimulus, it can be really difficult to treat. Testing-wise, we have the VNG, right? That's like one of the main things that we do to test people with dizziness or vertigo. But that is seated with those vertical lines, black and white lines, that go to the left and go to the right. And that's pretty much all we do. And then for vestibular physical therapy, how we treat it is, habituation, adaptation, substitution. But what do we know from evidence-based practice? How are we going to treat this? Clinicians, what do you do for an individual that has these needs? Researchers, how do you consistently and reliably do this for each subject? Well, I'm going to show you. That's what we're doing. This is Optokinetic Stimulus with roll. It's not her. It's a black and white screen with an image taken with a color video. So the next one I'm going to show you is her, and you cannot see it so well because it's a black and white image taken with a black and white video camera. You can see how this gentleman with that roll, he is highly visually weighted for his balance, and that is why he's losing his balance with that roll. So this is her. We can't see the screen, like I said, except for some shadows. The one on the left is playing right now, and this is her at the beginning. And I can kind of speed it up. You might be able to see a little bit of those shadows, and then she loses her balance to the right. And then this one is 3 months later, same thing. If I speed it up, you might be able to see the shadows a little bit of that roll, and she is keeping her balance. She's maintaining it. Remember, traditional testing, again, doesn't look for anything other than left and right lines. Why? It's research, it's evidence-based practice. If we don't do the research on this and don't publish it, then we continue to miss things. We have gaps in our treatment, our assessments, everything that we're working with these patients for. So guess what? Guess what my first research project was? I told you I was an accidental researcher. Okay, so the first person to put it correctly in the chat, Eric will give them a DIH water bottle. I have no idea if he will. We didn't talk about that, but I think you should try. Let me show you a little bit more. We also integrated, by we I mean Bill, integrated Tobbi glasses with our treatment. Tobbi glasses have cameras that allow us to see the eyes, which you can see in the bottom portion of each of those panels. And then we also have cameras that point out so we can see that gaze fixation point. That's that red circle. The screens at the bottom are showing you the vertical. So we do the right and left traditional. We also do the up and down, which you can see on the horizontal lines. The screens at the top, again, are those black and white images, so it's hard for us to show you, but the top left is showing us the tunnel, which go in and out for that optic flow. And then the roll that you saw earlier, the right and left roll, is on that upper right. This allows us to see and look at their eyes, so that nystagmus, real time, their gaze fixation, real time, as well as their balance. It's all in one place, and you just can't do that in the clinic. You've seen the impact of the CAREN, at least what I showed you, on patient-centered care. The technology was adapting to the patient's needs and our goals. It is truly science-backed and patient-driven. We need translational collaboration to benefit everyone. We have treated patients while publishing papers. Well, I mean, right now, posters. We've published posters. Let me show you. The reason we have published posters and not as much articles is because of time of writing, but I promise you it's coming. Some of these I've highlighted is what I've done with other disciplines as well. So we have the diagnosis and treatment of visual midline shift syndrome that I did with optometry. Real-time ability to see what was going on with them, plus give them those prisms in an accurate way. Sent them home with treatment that helped them that day. All right, another one is improving speech intelligibility and gait in people with Parkinson's. So that was myself and speech language pathology. I joked that I got them walking and they got them talking. We were able to see really nice gains on the CAREN with that. And we have the postural response to optokinetic stimulation, which was, hopefully somebody wrote it in there because that's the right answer. They get the water bottle. I am still writing this. We wrapped up a while ago, but I am not a PhD. So I promise you it's coming out. And then we just actually finished our motion sickness glasses study, which was fascinating. And we are planning on sending that to the publisher, hopefully in September for the first round. Now, I hope you have an understanding of the CAREN's dual role. You recognize how clinical cases drive research and vice versa. You can identify collaborative opportunities. We would love to turn all clinical challenges into research wins. Now is my favorite time, which is questions and answers. So let me, try to take away my screen.
Okay, so we do have quite a few questions, so keep them coming in, and I'll try to kind of organize them in some of the way that they kind of carry on into one another. So I guess first one is, would you say that you can use the CAREN on SCI patients with hemiplegia?
Spinal cord injury patients with hemiplegia, yes, you can. So they have a split belt treadmill. So you can have one side go faster or slower than the other. You can do a lot with it. Plus, you have a safety harness on, and then you have kind of the lasers at the back and the front are kind of like garage door openers, or not openers, the safety features in garage doors. So if you pass it, everything stops. So absolutely, you can use it with spinal cord injuries, and we have.
Okay, so we have another one here. So question says, from my clinical experience, I've noticed that many stroke patients using the CAREN system show good progression in the first 2 to 3 weeks, but after about a month, they often regress to their previous functional level. Could you share your insights on why that might happen and how that could be addressed?
Ooh, good question. So I love getting at what they want to do and then also what they think is impossible to do. So we start out like those easy gains, right? Learning how to reuse in a very specific area. But then if they want to go further, so for example, if they want to dance again, if they want to hike, if they want to do something that's really salient to them, we challenge them. And then we say, do you think you could do X, Y, Z? And they say, oh, no, that's impossible. So then we keep kind of driving at that. Well, if it's impossible, let's try it. So that's kind of how I look at it.
Okay, so I think this one may be a little bit more for your good thoughts. So what would you say is the prescribed treatment course? So this question asks specifically about the last case, but if you want to expand on some of the others, like how would you decide you described what you were prescribing as far as your treatment, the repetitions, time, duration, all of that?
Oh, okay. So are you talking about like optokinetic stimulus in general or MdDS specifically?
So this one says in the last case that she improved. So I think this one is about the mal de débarquement, okay. Which is how many times she practiced on the CAREN. So was it like 3 times, 2 times, and
yes.
If you also don't have a specific answer, there the group that's out of Mount Sinai that's done some work, as well as Brooke Army Medical Center, if you know about those, to speak on those as well.
Yeah, so it's their research that I looked up. So that's exactly what we used. So for this patient, I had her doing a lot at home as well. And as you know, you can't get on the CAREN at home. So we were using some of the things from Emory University that they have online with the lines. And then we also were doing some things in the clinic with alternating objects and then getting on the CAREN. At that time for her, we did see her for about 3 months, and we saw her on the CAREN about once a week.
Okay, so I think we have kind of our first one for Bill. So we have a couple related questions, which are essentially like what kind of information is needed? Like, how are you getting started with the overall development process of the applications? And like, what does that look like? And, you know, some of them have information, some don't. So what are you kind of doing in your process?
Yeah, so a lot of everything is clinician or patient driven, honestly, at Midwestern. So if you look at the horseback riding app, that one honestly started because we had actually 2 patients at the time who were both trying to get back to horseback riding. And Celeste came to me and asked if that would be possible to do on the CAREN. So honestly, my starting point was to get the platform moving in a similar manner as a horse would from its back. So honestly, I started at ChatGPT and had it write me some Lua code as a starting point. And then from there, I did a lot of research on just watching videos of horses and how they move. Tried to look up research on if there was any public data set for kind of that horseback motion. And then honestly, it came down to the patient and the patient's husband, who were both avid horseback riders. And I got it to the point by kind of getting the movement and watching videos and kind of adjusting the periods and amplitudes of each of the 6 degrees of freedom on the platform. But honestly, they had invaluable feedback just with their experience in riding horses so much that I was able to even fine tune it a little bit more. And by the end of it, the patient closed their eyes and said that it felt like she was on a horse. So that was pretty cool to hear. But every application is a little different. It just kind of depends on what we're working on, but they are almost always either patient driven or clinician driven.
Okay, we've got quite a few more in that I haven't categorized with an organization to how to go for that. But do you think that some of these implementations that you've done, are they feasible to implement within a clinical setting? So oftentimes you might be limited by how long you have to see patients. So how do you work in the time and the number of sessions that you're given with patients to doing some of these more intensive activities?
Yeah, that's an awesome question and a daunting one for me at first. So I agree. How are you going to fit it in? So what I end up doing is seeing the patient usually in the clinic I usually see patients for about about an hour because of the complexity of the patient population that I see. Usually the first half an hour we'll do in the clinic and the second half hour we'll do in the CAREN. So I can split up that time. There's the first patient that we had on, I see him on the CAREN and the Andago only. I don't see him in the clinic. But you can use the CAREN even 15 minutes. So these applications I showed you are not necessarily long, or the thing that you want to work on does not have to be a long thing. We have other disciplines that, like vision therapy, that do only use it for 15 minutes. So there is plenty of time in your session. We don't have to do full marker sets for any of the applications. There's the human body model, the gait analysis. We will need to do a longer marker set, but it doesn't need to be. So you don't have to have the patient on there for very long, and the setup time is not necessarily long. So there is time for you to put the patient on the CAREN.
Okay, thank you. So we have a few questions that are, I guess, more patient specific as well. So I'll try and generalize the question some maybe. So how do you determine any indications or contraindications for patients that you would put onto the system, and maybe figuring out which type of applications that are either, let's say, the pre-built ones, or when you need to design and implement your own, how are you kind of fitting those to the particular patients?
Oh, that's a great question. All right, so I start with an evaluation like we all do, and that is in the clinic. So at that time, we figure out what the patient's needs are. Now, most of my patients do get on the CAREN, but not all of them, because they're not all appropriate for it. Now, anybody that's having gait or balance issues is appropriate for it. Like, as long as they can walk out onto the CAREN, and even some people have been wheeled out onto the CAREN, as long as they can stand. We're working with different things. So I'm trying to think maybe if someone was very cognitively involved, if they couldn't understand the directions, we wouldn't have the person on there. I actually have a patient right now who is at pretty severe Alzheimer's, so I will not get him on it. But most patients are appropriate for it. And then anything that's a visual cue, and you saw we started out standing without the platform moving at all, or the treadmill moving at all. You can make it easier or harder on the patient. So your main question was, how do I figure out who's appropriate for it? Evaluation. And then what applications do we use? The application that they need. So whether it's gait or balance, or if they need to start having more cognitive load, more things to work on for real life training. And then as far as specific or custom applications, like we showed you with the horseback riding one, we needed that. And so that's specifically what we asked Bill for. So that's kind of how we decide all of those logical steps to get on the CAREN.
Okay, so I think we have kind of our first one about the eye tracking. So are there any programs that help stroke patients improve eye tracking and focus and to maintain those improvements over time?
Excellent question. So eye movements, we can do a lot with, if you're talking about like saccades or smooth pursuit, there is a lot of published information already for the clinic use, both in physical therapy, occupational therapy, vision therapy. There's a lot already with that. For specifics on the CAREN, I have not come across any for that, but we have another application that we made where we have a ball going back and forth. So we have them, they can follow it, and we can have those eye trackers on them to see if they're actually leading that ball, if they're behind the ball. We can see what they're doing and cue them, versus in the clinic, sometimes it's hard for them to see that. And we don't have any specific data on that, though, for the CAREN.
So this one is asked in kind of quite a few questions. So I think in general, it ties together. So maybe a question a little bit more for Bill. So a lot of these, you've taken some of the pre-built applications as well as you've done some of them yourselves. So how would you say it is easy to implement them? And do you feel that that's something that you could take from this system and maybe apply it to more of some of that real world application that you mentioned, maybe even something kind of like what you showed with walking on the Andago, which is getting maybe out of the lab? And how can we transition what you're finding and the work that you're doing on this system into the normal daily life?
Yeah, so I think the CAREN is such a great tool because it's so adaptable, and there are so many applications that you can build and different scenarios you can put someone in. But obviously, it takes up a big footprint. It's a pretty significant investment. So I think there are a lot of the applications that are built on the CAREN, or that you could build on the CAREN, that you could recreate either for a clinic or for home use, just for a specific application. But again, it's such a nice tool to be able to develop either that idea or that method of treating something. And then, yeah, I do think that there is room to then take it to somewhere else. For example, we had another physical therapist who wanted to give kind of that extrinsic feedback that you get from the human body model, but be able to do it in the clinic so that they could do it over ground in more space. So I've been working on some computer vision to track people as they're in the clinic, and then apply that to a 3D model that they can then view, which the physical therapist, again, can give that extrinsic feedback to. So I do think there is probably unlimited opportunity for that transfer of kind of creating new technologies. But again, it's nice that the CAREN can kind of do all of them. So you can use that as a place for prototyping and developing, and then try to find those things that might be useful to then create for other places as well.
So I think this question kind of ties in to the last question, as well as one that was asked earlier. So they said they were noticing or wondering whether there were improvements in the daily activities of the patient. Did they report increased balance or improved gait with the session? So how are you working with the patients to monitor objectively their progress, as well as how they're feeling over time? And have you come up with somewhat of a recipe or a program that you know that this is probably something that we can generalize across populations?
Ooh, okay. Good question. In general, when we're working with a patient in the clinic, we always are trying to get them to understand their body, right? So no matter what we're working with, we're wanting them to improve something: gait balance, movement, range of motion, whatever it is. We want to have them have those internal cues versus external cues. So my answer would be having the patient understand it in real time on the CAREN. That is what we focus on. So did you notice your leg did this? How did it feel? Like that sort of those cues that we do before and after, and sometimes even during the applications. Then we focus on that walking out. So can you feel the same thing? Can you feel your knee snapping back? Can you feel the weight on your leg the same as you did on the CAREN? So just having those discussions about how the patient is understanding their body and trying to have those carryover moments into real life. And then that is part of their homework. No matter what body part we're working on or what diagnosis we're working on, can you feel it? Can you do it? Can you kind of internalize what you just felt and continue working on that on your own in real life?
So I think we have another one for Bill. So for the application with the various horse gaits, so you mentioned that you got some feedback from the patient as well as from her husband. How did you design the initial movement of the platform? Did you do like any accelerometry on horses? Is that even a thing? So how did you come up with the general plan for how you were going to make the platform move?
I do know that there are people that have done the accelerometry of horses, but I didn't have access to that data. So again, I started with ChatGPT as to get kind of the scaffolding of the code. Again, I'm never using that just before putting a patient on there, but it's a good starting point so I don't have to do as much typing. And then from there, I adjusted all the parameters like the period between the oscillation in a single direction or the amplitude or kind of controlling the speed at which it's moving. And then from there, I kind of pulled up some videos on YouTube of horses doing the different horse gaits and kind of observed the platform and the horse at the same time and tried to match it up the best that I could. And then again, it just came down to the patient trying it out, saying what felt a little different to them, as well as the patient's husband also did a lot of horseback riding and horseback training, actually. So they actually, I think, kind of helped us to kind of push that gap because they were really the experts in the horse gait and what it should feel like to be on the back of a horse. So that was super helpful. And then actually one thing that I didn't mention is obviously horses are going to make unexpected movements. So we also used the controller module to hook up an Xbox controller and gave the controller to her husband, who was making it move kind of unexpectedly like a horse might, on top of the normal movements that a horse would be making.
So without getting into the weeds too much on particular disorders, I will address this particular question because we often see stroke patients as one of the most utilized kind of on the system. So do you have any recommended frequency and duration of CAREN sessions for stroke patients?
That's an excellent question. We need more evidence-based practice. So I would love to talk to other CAREN users too and see what they do. For the most part, at least once a week, I have them on there for at least 30 minutes. Now, what is the optimum amount of time? I don't know. We know that making changes and bringing in complexities are so vital, so important to get back to what we can do with the brain changing, especially in that first year. So I would love to know that answer. But for me, at least once a week, at least a half an hour is what I'm doing.
Another one for Bill. What would your advice be for someone who's just getting into scene development or building these custom applications, maybe outside of ChatGPT?
Yeah, I mean, there's so many different kind of hats that you take on when you're building custom applications, because you have to do the 3D modeling. Anytime you want those models to move, you have to do some animation. There's programming. If you want to output the data to analyze after, you're doing data analysis. So honestly, picking any one of those and starting and trying to become an expert in it is going to be very helpful. I do think ChatGPT has become a lot more helpful. I don't know if anybody's asked it about CAREN systems, but it does seem to know more than you would think, with it being such a unique device, an advanced device. But it does do a good job, again, of kind of creating the little snippets of Lua code that you might use in your scripting module. That's drastically cut down on my development time, I know. There's a lot of tools now that you can use, as well as libraries where you can find 3D models. That's what I found to be the most time consuming, is any 3D model that you need. I don't really have any formal 3D modeling training or education, so I feel like that's always what takes me the longest. But honestly, it comes down to, I think, either you coming up with a good idea for an application, or someone else bringing a good idea to you. And a lot of times, at least for me, that's very motivating to then spend the time to learn whatever is needed to make that happen. But yeah, again, each application's different on what is difficult with it. So yeah.
So you showed us 3 different types of patients. However, none of them were children. Do you have any experience treating pediatric patients? And if so, do you have any insights?
So first, for me, I am a geriatric clinical specialist. I treat everybody except for pediatrics. So I'm going to let Bill answer that question for the CAREN part.
So we have had several. I'd say the main clinics that have used it for pediatric patients would be Sports Vision. So we have various things working on either visual tracking or reaction time, different things like that. We've had some occupational therapy, although that's pretty limited for what we've had on so far. And we've had some speech language pathology as well. A lot of times, I'd say one of the most difficult things with pediatrics is they see it a lot of times as a big video game and are less focused on what we are for why they're there, which can be a blessing and a curse, because that does kind of get them more involved and actively doing maybe what we want them to, but sometimes maybe they're only focusing on the game where we want them focusing on something else.
Okay, so as we are kind of coming up towards the end here, I feel like I've answered I've addressed most of the questions in the Q&A, but if I have not gotten to your question, go ahead and just retype that in really quickly. And in the meantime, I'll kind of lead in with sort of a final question. So of course, everything that you all presented is really cool stuff. And I imagine that a lot of people would probably want something similar. So outside of like a cloning machine, how can we get our own Bill?
That's a good question.
You can't have mine.
Obviously, there's a lot of talented people that can do what I do. I think it just comes down to the motivation and interest in using the CAREN, because it is, honestly, if you think about our patients coming and seeing that, it's intimidating. When you first come in and you're asked to run it, it's kind of equally like that. So just being able to spend time with it and get comfortable with it. Yeah, I don't know if you have any thoughts.
Yeah, I mean, having somebody that is willing to discuss what the clinician, the researcher needs or wants, is really helpful. Bill and I have worked together for over 5 years now, and like I said before, he has brilliant questions. So if you're interested in doing what Bill does, just being interested in movement, in therapy, in what the human condition, and being willing to kind of put yourself out there and learn something new to help those patients or subjects.
Okay, so I think just the last couple here. So I think this one ties in a little bit to the optokinetic stripes that you were showing on the screen. So they noticed that since the CAREN has video projection and it's on a curved screen, do you see any issues with using it for an extended period of time, whether that's like motion sickness or any kind of issues with that?
Good question. The research I did on optokinetic stimulation is never more than a minute. So we did 30 seconds, and that's what I usually continue to do is 30 seconds, because we're not trying to make people motion sick. We're trying to see how they are reacting with their balance with that optokinetic stimulation and their symptoms. So those are the two things we're looking at. So we do not do it for very long. Again, 30 seconds is usually our limit for the purpose of having the patients see that. And then the curve of the screen, I thought you were going to go somewhere different with that. So Bill is able to use his technical prowess to have those 3 cameras be able to keep a straight line on that curved screen. And that's actually where I thought that question was going. But if you want to make people motion sick, we also now have an application for that, to test motion sickness. We have to make them motion sick in order to test to see if our motion sickness protocol is working.
Okay, I think we have time for probably just one more. How can someone determine if like the CAREN is appropriate fit for their institution, and like who would be, I guess, good to get information on that?
All right. So,
and I think actually that one also has some contact information in the chat as well.
All right. So who would be good to be the contact person for you? Okay, so are we talking about like a researcher versus a clinician? Because I think you could look at a couple different
so I would say in general, so you mentioned like collaboration, so I'll kind of expand the question there. How are you finding someone that you could potentially collaborate with? So I know that you're looking at doing research posters and hopefully getting publications. How are you finding people that you might be able to collaborate with, whether that's the researchers or clinicians?
Good question. I haven't found many. So we would love for anybody on this call that is interested in collaborating to not only talk to us, but talk to each other. I think, Eric, you also might be the person to talk to as far as getting people together to talk about what they're doing with the CAREN, as well as I think one of your questions was how to obtain one. So I think that might be a you question.
I don't have the answer for that. Yeah, that's a good ChatGPT question. But I would say, so we are kind of coming up to the end of the hour here. So if we missed questions that are in the Q&A, when you post those, they do have your email. So we can reach out to you at the end, and we'll get back to you as soon as possible with some of those questions. And I realized before I'm sharing not the end screen, so let me put up the contact information for Bill and Celeste for if you have any remaining questions.
Yes, please ask us, because we love our job. And we love talking about the CAREN, and we would honestly love collaboration, whether that is something you need help with or we need your help with. Talking and collaborating really will make us all better researchers, clinicians, and get those patient outcomes that we want.
Celeste and Bill, thank you so much for all your information today and for all the participants for attending the DIH webinar. If you do have any additional questions regarding the CAREN system, Andrew Zwart and Allison Crumpy's emails are in the chat. So feel free to reach out to us at DIH with any questions and to see if a CAREN is a good fit for your facility. And thank you so much for putting up your emails on the screen there for additional collaboration.
Thank you.